Welcome to Beyond the Scale, where we delve into transformative stories of business owners who have harnessed the power of body composition to elevate not only their own enterprises, but also the lives of their customers and patients. I'm your host, Bradley from InBody. Today, we're going to go beyond the numbers on the scale to explore the profound impact that body composition can have on chronic disease care. From deep insights into how to identify, monitor, and reverse chronic disease, to an innovative new software called CureCoach, where providers can connect with patients to collaborate and deliver optimal care and results. If you have an InBody or thinking about getting one and you provide care for chronic disease for your patients, you won't want to miss this conversation. So without further ado, let's go deep beyond the scale into the intersection of healthcare and body composition right here with our guest today, Dr. Craig Bax. He's been a super user of the InBody technology for more than a decade at the Cure Center for Chronic Disease in Illinois. Since founding the Cure Center, Dr. Bax has begun to help cure chronic disease on a bigger level through his newest venture called CureCoach, where he brings patients and providers together to collaborate through early detection of disease states and delivery of care to achieve longer, healthier, and more secure lives. Welcome, Dr. Bax. Thank you for joining us.
It's great to be here. Thank you for inviting me.
My pleasure. How are you doing today?
Really good. Even better
Good.
now that I'm here on your podcast. I'm glad to be a guest.
Thank you. Yeah, I'm excited to have started to do this and really want to go beyond just the scale and get into some deeper insights on how
Yeah.
many different people have been using the InBody. So I'm excited to chat with you. I've been excited about this one for a while. So tell me more about, where did you get your start in medicine?
So I did my undergraduate at Valparaiso University, graduated there with a bachelor's in chemistry and biology. I knew from about my sophomore year in high school that I wanted to be a physician. I was told I had the aptitude, I had the grades, I had the ability to master the work, and I had the desire to use my talents to help take care of others, and seemed like a pretty good way of doing well while doing good. A small town uh, kid with a blue collar background, so I was lucky and fortunate enough to have the performance to get into medical school at SIU School of Medicine and graduated from there in 1981. Like problem solving, so I gravitated toward internal medicine, like working with people and on a chronic relationship sort of basis. And that's been my career for the last 40 years.
Wonderful. How has that turned into the mission that you're on today? Because that's 40 years later. How has
Yeah.
it shaped you?
Yeah. Well, for the first 30 years, I did traditional internal medicine. I did spend about 3 years as a chief medical officer at a hospital for kind of herding the cats of the medical staff, dealing with process problems, system problems. So I learned a lot about process improvement at that point. But I left that position in 2010, and I found myself in need of a job until I retired, which I don't plan to do, frankly, ever. I retire every night before when I go to bed. But the rest of it, I think that retirement's highly overrated. But at any rate, I re-engaged my practice as a solo practitioner. But in the process, I attended a lipid meeting, and they were doing carotid ultrasound in the back of the room and offering it for free. And I thought, what do I have to lose? And it confirmed that I have arterial disease. So it became personal, and I started to investigate, how does one do more to stop the progression of arterial disease, to reduce the risk of stroke and heart attack, which had affected both of my parents, who have since deceased. And I wanted to live longer and be there for my family, my patients, and so that led me to the Baldwin method. We can go into that in more detail if we have time, but the point is that a big part of that was nutrition management. And I forget where I first was exposed to. Well, I guess I was exposed to the concept of body composition analysis. I had a DEXA scan done, And, I thought that was intriguing information. And then I learned about bioimpedance technology. I can't remember the name of one of your competitors, but I was exposed to an option that involved laying on a bed and attaching a bunch of leads to a patient. It seemed rather cumbersome. And then somebody told me about the InBody, and it just so happened that there was a physical trainer who had one right down the street, and it continues to have one. In fact, here in Springfield, Illinois, we may have the highest density of two InBody 570s located next to each other because we're literally one block apart. And so I went to see his, and I said, "My God, this can't be this simple to get this much information. How does this, work?" I thought it was like magic. And so I investigated further, and I bought my own, and it's been my most cost-effective employee. It's like a robotic coach, and we call it the judge. And everybody who comes in the office for whatever reason, part of an appointment, they get to first stop by the judge and get their see what they're made of.
I want to dial it back here for a minute and
Mhm.
talk about heart attack, stroke, arterial disease. I know it's something that affects a lot of people, and you even sense that it was impacting you. Tell me more about what causes heart attacks and strokes, maybe more about like the pathophysiology that's at play there with that.
But ultimately, atherosclerosis is the number one cause of death and disability in the Western world. And it remains the number one in spite of all of our efforts to reduce its impact using statins and controlling cholesterol and hypertension, make great inroads in terms of smoking. But what I learned from the Bale Donine method is that it's far more preventable, far more reversible than I was led to believe from my prior training, and that the things that we've paid close attention to, like cholesterol and hypertension, may be less important than sugar in our diet and starches and how often we eat and when we eat. And so but ultimately what atherosclerosis boils down to is it's an inflammatory condition in the wall of the artery. I use the analogy of acne. If you have acne, you have inflammation in the skin, and there are certain points in the skin where pimples pop up, and that's what atherosclerotic plaque is, for lack of a better analogy. And I can show you images, but just think of when a pimple ruptures, you get a blood clot to heal that rupture, but it's that blood clot that forms inside the lumen of the artery that affects or may interrupt blood flow and causes stroke in the case of a plaque rupturing in the carotid arteries, or in the coronary arteries, it would lead to a heart attack. And so this inflammatory process has many different drivers: oxidized LDL, insulin resistance, which precedes pre-diabetes and diabetes for many decades, periodontal disease, so the dentists are caring for conditions that, and particularly the hygienists are caring for conditions that contribute to this. And this is all brought to bear, among other things, that just about anything that can increase chronic inflammation. And I would say most recently, our experience with COVID and potentially the COVID vaccines, let's just say the spike protein, whether by infection or injection, I think has exacerbated that inflammatory process and put people at more risk. So the crux of the effort to reduce its impact comes down to reducing chronic inflammation, which I think we're all learning that that is a common pathway for not only cardiometabolic disease, but probably cancer, depression, just all kinds of things that are first world problems in the Western world. Since we've largely conquered much of acute infectious disease, now we get to deal with all these chronic diseases that are killing us slowly.
Tell me more about how the InBody fit that equation. How do you use it? And are there specific outputs that you're looking at when somebody's coming in to determine their risk factors related to this?
That's a great question. And, I've always um, I like light bulb jokes. So how many doctors does it take to change a light bulb? And the answer is only one, but first the light bulb has to be willing to change. And for most of us, we need some kind of message, pain point to induce change. And we all know that our population generally is becoming more obese, more diabetic, more chronically inflamed, more dysmetabolic. And so I've always felt that it's helpful to have a tool to get somebody's attention. Change typically doesn't happen until somebody has a reason, and that means get their attention. So I use the InBody as a way to first get somebody's attention to motivate them, but it also is a way to measure their progress and either correct inadequacies in their lifestyle changes, or more importantly, to reinforce the progress that they're making in a way that you can't tell from the scale alone. And it's also very impersonal and objective, and it's harder for people to um, debate. So, I mean, if I tell you, hey, I think you need to lose some weight, that feels very personal. But if the machine tells somebody your percent body fat is 30% and a healthy level would be 10 to 20 for a male, then it's just a number. It's less personal. It's less threatening, if you will, especially if you can say, well, and here's some simple things that we can do with your diet starting today that can improve those numbers. So one of the things that I really like about the device, first of all, it's intriguing. It's cool. People kind of think, well, geez, how does this work? It's like magic. And I try to explain to them about, bioimpedance absorption and, how electrical impulses are absorbed by fat and transmitted by water and muscle. But it's, I kind of give it a little bit of a technical, but at the end of the day, it tells you what you're made of. And it's such a better conversation to have with a patient to say, here are your numbers. Here is the trend. Does this surprise you? And the answer is generally no. I don't have to do an interrogation about their diet and their exercise. They'll just kind of spill it all out. And so even though it's somewhat difficult to create it, say, well, I bought this machine and I'm making this kind of return on my investment financially. When I look at the enhanced effectiveness of our program because of the numbers that we get, because when I look at the enhanced efficiency of a patient encounter, when I look at the lack of sort of the contentious, things that go around weight and fat, I would say, fat is the F word. I can't say anymore. You can get away with saying the other F word, I think, more readily in this day and age than to say, the fat. But, it just makes it so much less personally offensive to look at the numbers and say, look, these are not the numbers that I'm giving you. The machine is giving you. I don't like to judge people, so I bought a machine that does it for me. And that seems to kind of introduce kind of break some of the tension, and make it just about, okay, here's the problem. Now, what are we going to do to address the problem? And so it changes the conversation dramatically from what I was used to in trying to motivate my patients to lose fat. And that's another aspect to this. It's like people get kind of hung up on, well, I want to lose weight. No, you don't want to lose muscle weight. You don't want to get dehydrated. You want to lose fat, and in particular that inflammatory fat. And so having that visceral fat identification, which is one of the advantages I see of the 5, is that, however it's reported, it does tend to parallel the percent body fat pretty closely, but nevertheless, being able to point to that number and say, this is the number that will make you diabetic if that stays this way. And in fact, it says to me that you are, if not pre-diabetic based on your hemoglobin A1C and your glucose, you are insulin resistant, or what I call pre-diabetic. And that's a problem because it's a chronic inflammatory state because of hyperinsulinemia, hypertriglyceridemia, and the inflammatory drivers that go along with that.
Yeah, also sounds like a lot of relationship to metabolic syndrome here.
Totally. It's to me, it's the number that you can attach to say, this is how bad your metabolic syndrome is. If your visceral fat is 20 and it's been that way, you're highly out of balance metabolic. If your visceral fat is 5, or then you're probably very minimally insulin resistant. One of the things that I think people need to understand is that insulin resistance is not a bug in our software; it's actually a feature. The problem is that it's a feature that allows us to thrive in a feast alternating with fasting type of environment. So the hunter gatherer, that's where our genes, were selected or came from. But our culture has changed us into grazers, 3 meals a day, 3 snacks, as if we're all type 1 diabetics using old insulin preparations and needing to balance those things out. It's very archaic and it's very misguided. So that's why, having that information to motivate people to change, adapt more of a lifestyle that fits with the insulin resistance software that we're programmed with is so powerful and reinforcing. So I just, and, again, having the data and the ability to see the trends and the gamification that goes along, how do I beat my numbers? How do I improve? Is the difference between success and failure in my before InBody versus not, having this tool at our disposal.
Tell me more about how a conversation goes between you and a patient after the result sheet comes out. How do you introduce it? What kind of things are you talking
Mhm.
about and educating patients on?
Well, for anybody who's familiar with the sheet, of course, it gives their weight, and then it shows the muscle mass and then the body fat mass. And we go into, the three general patterns, the C, I, and D patterns. We see a lot of C patterns, people with excess body fat and an inadequate amount of muscle to balance that out. And in particular, it's mostly postmenopausal women, but the skinny fat concept, the fact that it uncovers people with quote normal or healthy body weight, but they're fat on the outside, thin on the outside, fat on the inside, or TOFI, if you will. So we get into a lot of conversations like that. I tend not to spend a lot of time dwelling on the lean muscle mass balance. I think that's more of a performance issue for like physical therapists and personal trainers to follow, development of muscle mass. But then I jump to the visceral fat showing and showing where they are in the 1 to 20 range, and then set a goal of at least less than 10, getting there one step at a time. And then also, of course, look at the ECW versus over TBW ratio as an indicator of dehydration versus salt or water retention, so that they understand the relationships between, you can maintain your body weight, but if you're losing muscle and becoming more dehydrated and getting fatter at the same time, that's a completely different story than if your weight stays the same, but it's because your muscle mass has gone up, your body fat has gone down, and you may be better hydrated. Two totally different opposite terms, or opposite trends in terms of health, but still with the same weight number. So mostly it's about showing them where they are, giving them some relatively simple advice on how to improve the numbers. And the whole goal, people ask, well, what should my weight be? And I say less. What should my fat level be? Less. What should my exercise be? More. It's all about comparing ourselves to our former self and the future self as our goal. So it's my ideal situation is to have the patient get a baseline body composition on the InBody, and then come back to see the judge every 2 weeks so that they get that reinforcement or corrective information. Because we all know that in order to create new habits, it takes about, 4 to 6 cycles of behavior modification followed by measurement to to change, their lives.
How do the results, when they come back on those every 2 weeks or monthly or in a couple months, how is that impacting how you care for them?
Well, I think we all do better with deadlines and goals. If you measure it, it will improve. If we don't balance our checkbook, our finances are going to be out of whack. If we don't follow our investments, we're probably not going to, do very well. So just the simple fact of measuring things tends to make them get better. So that's what I find is, and the more precise we can be, the more credible those numbers can be, the better. And it's very rare that we see a patient actually challenge the numbers. And, and I think nobody likes, very few people like to admit that they're doing something they shouldn't be doing or, they were wrong. But I find that the precision of the numbers, I say, well, I know you don't agree with the numbers, but that's what it says. So let's see how things go over the next, till your next visit and see if they get better next time. That way, it's a lot less. It makes for a much more collaborative patient-physician or patient-provider relationship than well, you must be doing something with your diet. You must be, and then we can focus on, you know, just giving them the tools and make it less personal. One of the things I think is worth mentioning about having body composition analysis like the InBody, which is clearly I think it's the easiest, quickest way to get body composition analysis. Try lugging a DEXA machine into a like a health fair or something like that. Even though the InBody is, just pick it up under one arm, but it's still much more portable and accessible and affordable. But the point is, I don't know how somebody runs a weight loss management program without having this information that you get from body composition analysis at the same time. So the whole issue of things like quick weight loss programs, including semaglutide, for instance. One of the concerns is what kind of weight loss are we seeing? Is it fat or are they losing a lot of muscle? And there's some controversy about that. So it'd be helpful to be able to measure that and show patients, hey, in fact, this approach is maybe not helping you as much in terms of your health as you might think. It's taking your TOFI and making it worse, the fat thin on the outside, fat on the inside, or, making you even more skinny fat than you were, even though the scale says you're making headway. So I think to me, it's an indispensable tool. We have in our community, we have a bariatric and weight loss, management program, and they just use a scale and calculate BMI. And my response is, are you kidding me? It's just, quite frankly, I find it substandard care to not be delivering the detail that we get from the InBody.
Yeah, one of the things that it makes me think of is muscle quality. And when we think of like the actual structure of a cell, and there's water inside the cell and there's water outside the cell. And a lot of times when people are losing lean mass, they're losing water from inside the cell because, say, in a GLP-1, the the sugar is not binding with the water to get in the cell. So they're limiting their metabolic function inside the cell, I think, long term. Same kind of thing with a ketogenic diet. People are
Yeah.
depleting the sugar from inside the cells. And is that good long term? I don't know.
Well, it's always compared to what, so it's compared to, eating a high sugar, starchy diet and becoming a fattened up cow. No, I would say, achieving more toward ketosis is preferable. If somebody has life-threatening obesity, a short-term fix with, Ozempic or semaglutide would be, acceptable, but to do that without extensive counseling and other support for a more sustainable, meaningful fat reduction, metabolic balancing program, I think is frankly just unconscionable. But there's a lot of opportunists out there offering it, and I guess we'll see what the consequences are
Yeah,
sooner rather
there's
than later.
there's definitely people out there that I think that are doing it well with really holistic programs that are addressing
Yeah,
things surrounding it. And I think that's where you're at in that as well. Even though you're not offering them to your patients, I think you're
yeah.
doing them even a much better service in some cases than what people might even find otherwhere using the medication.
Well, if you have a successful program, why would you do something else? And I think the success in our program speaks for itself. And so why would I offer something that has so many unknowns associated with it? So, I don't judge people for doing what they think is best for their own health, but uh, they may not like my advice or they may not agree with it, but I owe it to them to give them the best advice that I know how. Acquiring things like an InBody, don't think of it as looking for so much a return on investment for what you can charge for the use of this tool. Think of this as what would it, where could you find for the same money uh, a coaching colleague, a person who can, you know, deliver as much useful information to a patient in a easily short period of time and amortize that cost over, as I amortize it over 7 or 8 years that I believe I've had mine, maybe even a little bit longer. Um, and it's one of the most cost-effective decisions I've ever made. So it's an extremely high value, even though the initial investment might be difficult to understand exactly how you're going to pay for it. It will pay for itself in so many ways that you know you just need to think outside the box a little bit compared to how do you get reimbursement, which always remains a challenge. But it I would do it all over again, only sooner if I had to do it all over again.
There's a lot that goes into, I think, measuring or monitoring chronic disease, and the InBody is a great tool for that. What other types of assessments are you doing with your patients to monitor their disease risk?
Well, so one of the I actually try to minimize the use of the word disease risk. To be perfectly frank, we measure disease. So we measure the presence of excess fat, and particularly visceral fat, as a measure of metabolic syndrome or insulin resistance. Another tool that we use is carotid ultrasound. This is a tool that I use to do a fairly powerful but somewhat limited ultrasound of the carotid arteries to measure inflammation and plaque formation in the carotid arteries as a way of getting the patient's attention and showing that they have a problem that's silent, but it could suddenly become very life threatening or threaten their way of life in terms of disability. And then, laboratory blood testing to measure inflammatory markers, lipid levels, blood glucose levels, vitamin D, homocysteine, and we do those on a periodic basis, typically every 3 to 6 months, depending on what the patient's stability level is. So in the beginning, our typical patient evaluation is, and I tend to say, look, let's scan first and ask questions later. Let's not go through the rigmarole and the exercise of figuring out if you're high risk, because if you're low risk but you have disease, what are we going to go with? The presence of the disease, right? And if you're high risk but you don't have the disease, well, why are we going to put you through treatment if we don't find the problem? So it's disease focused, disease measurement. We use carotid intimate media thickness ultrasound, which sometimes we use a certified sonographer with a standard technique. But recently we found that working with a company that I've worked with for over a decade, Basal Labs, that we're able to get adequate images with this butterfly ultrasound probe that fits in my pocket and plugs into my phone, and we can send the images to them and get a measurement of the patient's arterial age that we can then monitor over time to see, are they getting better? In other words, their arteries getting younger and less inflamed, or are they getting worse because something else happened that we didn't know about, or that we hadn't controlled for, or that we hadn't measured for? So it makes for um, a significantly more credible and objective way of measuring whether we're actually achieving results. And I think that these individual measurements that are very interesting, but at the end of the day, what occurred to me about a couple of years ago is like, when was the last time I had a patient suffer a stroke or a heart attack? And the answer was, I haven't had anybody suffer a stroke or a heart attack in the last 10 years. And I don't have an absolutely accurate number of patients but I know it's well over 1,000 cumulatively over that 10 years. So for that's, having the InBody to measure one of the biggest drivers of this process, which is insulin resistance, far more, quite frankly, important than cholesterol levels, has been a huge contributor to the success of our program for the patients that we follow.
For somebody like me who was born in the 80s and I have health risk for disease, how would you help me reverse or cure that?
Well, first of all, we would measure to see, do you have the disease in the first place? So if you're, let's say, so you're born in the 80s, so that means you're in your late 30s or early, maybe 40-ish. You're at that age where we start to see this disease process happening. And I would, so for one thing, very few, I would say the number of people in our population that don't have an elevated visceral fat level or percent body fat on the InBody is far less than 20%. Okay. Most, 80% of us have opportunities for improvement when it comes to the body composition changes that lead to insulin resistance, which is the number one driver. So, showing that, hey, you may think you're not overweight, but you're certainly not optimal. So that's one opportunity. The other is I would have you just take 5 minutes and let me take a look at the arteries in your neck, the carotid arteries, using the ultrasound to see if you're developing atherosclerotic plaque or if you have the inflammatory changes that will lead to plaque. And that's totally non-invasive, totally painless, inexpensive, and we can see the results right away. And now I'm training other providers, other doctors, dental hygienists, optometrists to do this in their office, and we're supporting them with the reading of the scans. I think the day will come when this technology will incorporate AI reading in real time to tell us there's some atherosclerotic plaque, and take out some of the human inconsistencies in reading these images. But I don't think that's very far off. So we're about to have a very scalable model for detecting the most lethal and most life-changing chronic diseases, that is heart attacks and strokes, and then you add in dementia as a long-term consequence, to really change the trajectory of our population health. Because let's face it, I mean, we are really in a very critical existential crisis as a society and population. It affects our, quality of life, our community well-being, our national security, if you will. One of the groups that I'm starting to work with, where there's a shortage of over-the-road truck drivers because they have a lot of health risk issues, and so we're working with a company called Truck Suite to see if we can develop a program that will reach drivers who are, nomads. They're wandering all over the country. They don't, but they do come together in one place in a travel plaza, for instance. Wouldn't it be interesting if we could track their body composition from one InBody to the next, one state to the next, 2 or 3 weeks apart, and show them that, yeah, if you change your diet and maybe get a little exercise while you're refueling your truck, you could actually see some improvement and prolong your career, reduce your risk of injury, accidents, reduce the risk of harming others, So I think those are all things where this kind of technology, if it were available in more places and easily accessible, would be amazing for our public health. Being a medical doctor, I think it's just unfortunate that the oral health and general health have been siloed and separated. And, I really don't have a great historical control or, an understanding of why that took place. But the most of us have more contact with our dental hygienists on an ongoing basis over the last 10 years than we have with our primary care physician, particularly in younger and middle age. And there's an increasing awareness that the health of our gums and the bacteria in the mouth and dental infections and old root canals and airway issues have significant impact on general health, and including cardiometabolic health. It's actually estimated that as much as a half of all heart attacks and strokes could be precipitated, excuse me, by an acute infectious process in the mouth, whether it's gum disease, inflammation, gingivitis, and periodontal disease, or if it's an infected root canal, what's commonly known as endodontal disease. And it's something that when you tell people that, I go like, yeah, I kind of heard that, but you know, tell me more. So, what better way to capture and make people aware than to offer these screening, or I would actually say disease awareness tools, where they already come in an examination. It takes, an InBody takes a couple of minutes, and most of that is taking their socks off and putting their socks back on. And the ultrasound takes about 5 minutes. And if we can make that easy and accessible and kind of routine, then the awareness would dramatically increase. And I've been doing this for a while now, and I have statistics that show in a typical dental practice, about 75% of the people who are scanned with the ultrasound have at least something worth talking about, either inflammation that will lead to plaque or actual plaque. And so in conversation, so the dentist or the hygienist scans the patient, we read the ultrasound, and then we reach out to the patient, offering them what we call a discovery call to review the results and then talk about the options for next steps. And so I think by doing so, we're just offering people more awareness of what's going on. And the reality is that, affects, we should assume we're all guilty until proven innocent. We all have these conditions until we're shown that we don't have them, is a better approach than the head in the sand approach that we've taken with cardiovascular disease and metabolic disease as a healthcare system over the last 20 to 30 years. Now, I would submit that, people will ask, well, why is it that we do it that way? Well, number one is that there's just incredible systemic inertia to change. The healthcare system, like any other bureaucracy, is very slow to change. It takes 20 to 30 years for new technologies to really come into common practice, and ideas, are today's mainstream at one time were, yesterday's heresy. So, the expression is that, progress occurs one funeral at a time. That is it's the thought leaders, die off and a new generation takes hold. That's how progress takes place, not because of new information, but because of new people in the leadership. So I think that the effort to bring this kind of easy to use, powerful, compelling, evidence-based, objective, information from technology and if patients think, hey, this is kind of cool too, is just an incredible opportunity to improve our individual and population health. So that's why I'm such a big fan.
Especially when the first sign that a lot of people have for something like a heart attack or stroke could possibly be death. I think that
Right.
leads well into
Or,
wanting to have some type of an assessment, especially if it's outside of them going to see a cardiologist or them going to see their internal
Right.
medicine doctor.
Right. Well, I emphasize the stroke risk more than the heart attack risk, to be perfectly frank, because I think we've all been kind of conditioned to think, well, my dad had a couple of stents. What's the big deal? You know, or even bypass surgery became so routine that it's almost, I remember offering screenings at a state employees health fair, and rather than hearing what I had to offer to reduce the risk of heart attack, they wanted to sort of regale me with the stories of their bypass surgery. you know, it's almost like a rite of passage, for the middle-aged older male. It's just kind of bizarre. And I think our healthcare system has sort of built itself on these heroic efforts to rescue people from the brink of death. It's all very interesting, exciting, makes for great TV, but it sucks, when your loved one is, suddenly stricken with a stroke on Christmas Eve, or it's extremely disruptive. So it's kind of going down a bit of a rabbit hole here, but the idea is we have to come up with a substitute alternative to that horrible event to get their attention and provoke some action. So this may be a little too off color for the podcast, but there's an expression that if you don't stop doing that, you'll go blind. So that and the expression is, well, how about if I do it till I need glasses? And so the idea of prevention is something that people talk about, avoidance of behavior that leads to a bad outcome. But at the end of the day, until you're shown that you at least need glasses and you're about to, that you could go blind because of this thing that you can actually see, whether it's a plaque in the arteries on ultrasound or it's a visceral fat level of 20 on the InBody, it's like, okay, all right, you got my attention. Now what do I do? And that has really been extremely powerful. Doesn't work for everybody. Some people just don't want to know, but we just, when the student is ready, the teacher will appear. And so that's a big part of why I've adopted the concept instead of as a physician, somebody who writes a prescription or performs a procedure to fix the problem. I'm here to coach, and that's a special kind of teaching. Coaches are a little different than your history teacher. The coach, you know, tells you how much you suck at a certain task, or how much you need to improve on this, and then gives you the skills and the tools to improve that, and then holds you accountable for it. And so there's that level of coaching for patients. And then my goal with my company, my endeavor with CureCoach Incorporated is to bring that coaching to other providers, so that we can spread and scale this opportunity to offer people what they aren't getting from anywhere else in the reactive healthcare system. So I position what I do, I call it proactive medicine, as opposed to reactive medicine, which is, call an ambulance when you have a stroke or a heart attack. And preventive is great, but the reality is that most of the population is well past the point of prevention. There's, they have more than one chronic condition that, is reversible, but they have to stop listening to the people who are making the problem worse in the first place. The food industry, the pharmaceutical industry, the culture in general that says you can have all this immediate gratification with no consequences. And you can't fight that with just platitudes. You need data, you need to show results, and you need to help people stay on track.
I once read that there are 4 reasons why people change their behaviors, and I can hear you alluding to some of them. One of them is that they hurt enough that they need to change to avoid that pain.
Yeah.
Another one is they see enough that it inspires them to change. We learn enough that we want to change, or we receive enough that we're able to change. And it really sounds like what you're offering people is all of those opportunities in one, to be able to have the opportunity to make a change.
Yeah, that's really a great way to put it. And I hadn't really thought of it entirely that way. But if you just tell somebody you got a problem, but you don't give them the tools, or the hope, that they can get better, then you're just being mean. You're just being, critical. And and yet, if you see somebody that has a problem and you have a solution for it, but you don't tell them about the problem because you're afraid of hurting their feelings, I mean, that's equally cruel. I think as a physician, I don't like to scare people. But unfortunately, fear is the number one motivator. Fear of loss is the number one motivator, other than acute pain, that gets people to act. And I think that's been shown by market researchers that people are more driven in their investing habits or however they deal with things. They're more focused on avoiding loss than they are at achieving gain. Now people who are athletes or who are highly motivated, they're a little different that way. But the vast majority of people, it takes fear, something negative, to get them to address the problem. And often, one of the things that I just recognize is that typically, in dealing with, I prefer to work with couples, when somebody has a spouse, because every good man knows that, they know exactly, we all know exactly what we want as soon as we're told by a good woman, right? And so if I can get the wife on board, I can generally get, the husbands, getting better, occasionally vice versa. But there's quite frankly, we owe it to our loved ones to prevent these things from happening to us. It's not selfish to, for me to want to live long and healthy. It's in fact, it's the opposite. It's selfish to let myself, become vulnerable in a way that I could avoid. So I try to convey that as an imperfect example myself, but still try to, walk the talk as much as possible.
Yeah, we've been talking a lot about, I think, older people, myself or older, having these risks and being able to identify them and change them. But for a baby boy or a girl that was born today, how would you raise that child to avoid risk as it relates to diet,
Oh,
exercise, lifestyle? What kind of things would be essential for that to prevent these risks later on in life?
fundamentally, is get them away from the messaging of popular culture. You know, keep them away from the screens, keep them away from television advertising that tells them that breakfast is the most important meal of the day, and let's have Fruit Loops, and, not to pick Captain Crunch, it's basically cake and candy. You know that these, try to instill. First of all, I would say to parents, your kids don't listen to what you say; they watch what you do. And if there's a disconnect, if you have a do as I say but not as I do habit, if you say you really shouldn't smoke, kid, or you really shouldn't drink, or you really should exercise when you're 200 pounds, you're not going to get through to them. So be a good example first of all. Kids do they follow what their parents do, not what they say. And don't underestimate the power of your ability to positively and negatively influence your children. Um, so I think that's fundamentally it's be a good example, do it yourself, and do your best to keep them away from messages that are seductive, because let's face it, sugar is an addicting drug. It makes us feel good. It tastes good. We never were intended to be exposed to this much of it. But, many things that feel good in the short term, have negative consequences in the long term. And we just need to instill in our children that, a certain amount of deferred benefit, deferred gratification, or delayed gratification is something that we all should be participating in.
If you had a magic wand and you could wave it now, what would you do culturally to help reverse the problems that you see today?
Well, first of all, I would say that devices like the InBody are kind of a magic wand because they they show the problem without all the other sort of confusion and distortion. Fundamentally, I would make chronic disease less profitable because I think that's unfortunately what's driving a lot of, I think that healthy food should be subsidized more than junk food, but unfortunately, it's the other way around because of our public policy. I would make it, quite frankly, one of the things that I'm hearing from at least one of the presidential candidates happens to be related to the last president who talked about physical fitness. You're too young, but in the 60s, when John F. Kennedy was president, uh, there was a national physical fitness program, an emphasis on physical fitness. Why? Well, we were in the midst of the Cold War, and everybody thought we were under threat. We had to be in fighting shape, and so the U.S. president's physical. I remember as a grade schooler, you had to be able to do a certain number of push-ups. You had to be able to do a certain number of pull-ups. That was expected. So I would probably bring back that expectation that it's no longer acceptable to be unable to function and be. It's not acceptable to allow yourself to be easy to kill. Not by a bullet or by a sword, but by a sugar cube or or what we eat. So I think that that's probably asking too much, but I think fundamentally what we need is leadership that says, "Hey, we can do better than this. We're better than this." And so that's that's more than one answer, I suppose. But at the end of the day, it's let's just try to get better instead of accepting that we're just going to have terrible health and that. I mean, it's shocking that after all the years and decades of improving life expectancy because of better plumbing, better engineering, better living conditions, better antibiotics, that this coming generation will be experience of lesser life expectancy than their parents. It's just unacceptable.
Tell me more about CureCoach.
I needed a scalable solution for my own practice, so that meant digital support for my care so that I could deliver it more efficiently and also in a way that you made use of digital technology, looking toward telemedicine as a goal. And so I started working with a software programmer to create a digital platform for my practice. And as we went through this, is that this is something that perhaps could become software as a service, so licensed to other similar practices. And so it's intended to help to gather information from patients in a way that is interactive, introduces kind of an element of gamification, maybe a little bit of fun, a little bit of education in the process. So when a patient and I send them the link, they fill it out. It takes them about 15, 20 minutes. Within a matter of about 30 seconds, I can scan their information because it's very visual and graphical and say, here is the three things where we need to focus. Your lifestyle, your oral health, not much we can do about your family history, but we can modify the outcomes. And so that it's all about taking a process that used to take hours and hours to do down to, a manageable amount of time, also eliminating the need for a lot of the travel. The CureCoach app is a platform that includes secure messaging. So I eliminate a lot of telephone tag, faxing by enabling secure sharing of documents, storage of documents from other sources, and text messaging back and forth between patients and myself and their other providers. Group texting brings everybody together in a conversation that needs to be collaborative. And so it's a relatively new endeavor. Um, Thanks for the opportunity to give it a little bit of a shout out to your audience. I would be happy to engage in a conversation about how it could be used in other providers' practices. If you want to take it for a spin, just type curecoach.app, curecoach.app into a browser window, and there's no app to download. It's a mobile friendly website. So we invite anybody who's curious if they want to check it out, and maybe someday we'll be have an API integration between InBody and their web access, which is part of that. I guess part of my inspiration for the CureCoach app is the fact that, I have, for instance, I have an ultrasound practice an hour from here in Morton that has an InBody. So when patients come in for their ultrasounds, get their InBody there, and I get that information into my InBody web access and can follow it. And so we don't have to spend hours of windshield time getting back and forth, to get that. It's all about the data transmits very seamlessly. So I think the future, much is made about, wearable technology, giving us constant feedback about our blood pressure, our glucose, our heart rhythms. It's all important. But the real thing that in my mind is having immediate access on the same thing where we get our entertainment and our interaction with our loved ones. It's there at our fingertips. We can access it at any time and use it to actually measure and improve health outcomes. Fundamentally need a new type of proactive disease, management. And I don't even want to say management. Our goal isn't to manage the disease, it's to get rid of it and its impact. And that is entirely possible. One of the things that I like to point out to, people who are unfamiliar, I think many of your viewers will be familiar with the concept of a blue zone. The areas where longevity seems to be, the norm in ways that it isn't elsewhere. And what is the characteristic? What are the things that make a blue zone? It is, this lesser incidence of chronic disease, and it comes down to, better food, better relationships, better community, more exposure to nature. So in a sense, I would say that the practice where I've described where not a single stroke or heart attack in 10 years in a patient population that's chosen for the presence of the disease. We don't bring back people who have no disease. We, come back in a year, we'll take a look at you to see if you're developing any problems. But so that's in a sense a kind of a blue zone. So, wouldn't it be wise to try to emulate that and to spread that type of process of care to others? And I believe that with the digital app, we can hardwire, or at least, kind of algorithmically build in some of the processes so that we can make this care more scalable and available and more consistent to get the same kind of results, across thousands of providers instead of just, a few. Well, Henry Ford said, whether you think you can or you can't, you're right. And so I think people deserve at least an opportunity to, again, how was it you said, to feel that pain or to see that threat, and then be given the hope and the tools and the ability to address that threat in a way that's measurable, and don't sell people short. Yeah, a lot of times people are going to fail, but addiction is a great model for a lot of what we deal with, behavior that's bad for us. But most people don't overcome an addiction the first time they quit. Relapse. But the idea is longer and longer periods between relapses until that relapse-free time lasts a lifetime. The same thing is true for sugar and processed foods and other things that are harmful to us. So I think we need to give people an opportunity to help them and help themselves improve. A big element of helping people is to figure out what motivates them. One person may not be motivated by their desire to make themselves healthier, but they want to be around, because they have a spouse who needs their care, or a special needs child, or somebody who is dependent upon them. And that's the whole concept of motivational interviewing. What is your why? What is your goal? If you don't know what somebody's why is, you're never going to, figure out how to motivate them. And it's going to be different for everybody. And sometimes it's really surprising. But I think the number one concept that I've tried to promote is that, before takeoff, they tell you with the oxygen mask drops out of the ceiling, you put it on yourself first before you try to assist others. If you try to assist others while you're passing out from hypoxia, you're worse than useless. You become part of the problem. So, I think motivating ourselves to use the information, not feel insulted by it, not feel threatened by it, see it as an opportunity to improve the numbers, and we can make some really good progress using those tools, like the InBody and the butterfly ultrasound, and there's a host of others, that I think are very worth applying to a proactive effort to actually just get rid of chronic disease. It's possible. We need a network, a supportive community of like-minded individuals, because God knows the mainstream healthcare system is not going to support us. In fact, they're going to fight us, because the mainstream healthcare system, including the payers, is largely dependent upon chronic disease as a source of revenue. We talk about high healthcare costs, but the providers see it as high healthcare revenue. So different deal.
If you already have an InBody, we'd love to hear about what you learned from this episode and how we can continue to serve you with other guests or ideas that you'd like us to discuss. If you are ready to get an InBody to help grow your business, you can visit special offer here from the CureCoach and Dr. Bax. If you go to learn.inbodyusa.com/CureCoach for a special offer, then one of our team will reach out to you there, and we will help you understand what we got going on, how we can help you. Anything else you want to share about where people can get in touch with you or connect with what you got going on?
My email address is Dr. Bax, drbax at thecurecenter.life. You can go on the curecenter.life website. And then the CureCoach.com is more of the software platform, and the CureScreen ultrasound service is how we can help other providers incorporate that into their practices with our support.
Anything else you want to share about where people can get in touch with you or connect with what you got going on?
My email address is Dr. Bax, drbax at thecurecenter.life. You can go on the curecenter.life website. And then the CureCoach.com is more of the software platform, and the CureScreen ultrasound service is how we can help other providers incorporate that into their practices with our support.